Okay, so we are done with rolling. We are done with margination, rolling, which is followed by adhesion. Adhesion, you very well know, is firm attachment of the leukocytes. Adhesion is firm attachment, firm attachment of leukocytes to endothelium. Adhesion is firm attachment of the leukocytes to the endothelium. Next point, how is adhesion taking place? Because of binding of high affinity integrins present on leukocytes with integrin ligands present on endothelial cells. That you very well know. So let us see the high affinity integrins. I can divide the high affinity integrins into beta 1 integrin and beta 2 integrin. The leukocyte receptor are integrins. Integrins are of two types, beta 1 integrin and beta 2 integrin. Beta 1 integrin are the VLA molecules. Beta 1 integrin are the VLA molecules, that is CD49A slash CD29, versus beta 2 integrin, which is LFA1 or MAC1. Beta 2 integrin, which is LFA1 or MAC1, that is CD11A slash CD18. CD11A slash CD18. But unfortunately, this needs to be remembered. So, adhesion occurs because of binding of integrins with integrin ligands. So, the integrin ligands were present on endothelial cells. So, ligands on endothelium for beta 1 integrin, for beta 1 integrin is VCAM1, vascular cell adhesion molecule 1, VCAM1, whereas for beta 2 integrin is ICAM1. This table is important. This is high affinity integrins present on leukocytes binding with endothelial ligands, binding with integrin ligands, that is VCAM1 and ICAM1. Next point. Next point. Now, before I go further, I'm very curious. You know that immunity is of two types, innate immunity and acquired immunity. Immunity immunity is of two types, innate immunity and acquired immunity. What is the basic difference between innate immunity and acquired immunity? Innate immunity, it has the same response to all stimuli. Innate immunity, it has same response. It has same response to all stimuli. Whereas acquired immunity is stimulus specific. Acquired immunity is stimulus specific. So in innate immunity, whether it is a bacterial infection, viral infection, or somebody has pinched you, it is the same response. So I can safely say specificity. I can safely say specificity, memory, and lag phase. Specificity, memory means 1 year ago you got a staph aureus infection. If it occurs again, innate immunity will not remember, whereas acquired immunity will have a stronger response. So specificity, memory, and lag phase are absent in innate immunity versus they are present in acquired immunity. They are present in acquired immunity. What is lag phase? Lag phase, this is the time period. This is the time period between stimulus and response. Time period between stimulus and response. How much is the lag? It is absent in innate versus present in acquired. This is basic of immunity. You know this. My question to you is, all these steps of inflammation, we did the steps of inflammation from margination to killing. These are the steps of inflammation. My question to you is, are these the steps of innate immunity or are they the steps of acquired immunity? Answer. These are the steps of innate immunity. See, whichever the stimulus, whichever the antigen, margination, rolling, adhesion, diabetes, chemotaxis, killing. These are the steps. So these are the steps of innate immunity. So if there is a problem in any one of these steps, it will be a disease of innate immunity. So this gets us to the diseases. This gets us to the diseases of innate immunity. We will study inflammation and immunity together. It is always easier that way. Diseases of innate immunity. Starting with the first disease of innate immunity, that is LAD1, which stands for leukocyte adhesion defect 1. Leukocyte adhesion defect 1, LAD1, which is a defect in adhesion. Which is a defect in adhesion. Next is LAD2. The next disease of innate immunity is LAD2, which is leukocyte adhesion defect 2, which is leukocyte adhesion defect 2, which is a defect in rolling, which is a defect in rolling. So LED1 was a defect in adhesion versus LED2, which is a defect in rolling. It is opposite. Rolling occurs before adhesion, but LED1 is a defect in adhesion, LED2 is a defect in rolling. Let us start with LED2. First point, both LED1 and LED2 are autosomal recessive. Both LED1 and LED2 are autosomal recessive. Next point, let us start with LED2. It is a defect in rolling. Rolling occurs because of binding of sialyl Lewis X glycoprotein present on leukocytes with selectins present on endothelial cells. So LED2, this is a defect in sialyl Lewis X glycoprotein. This is a defect in sialyl Lewis X glycoprotein. What is the defect? This sialyl Lewis X glycoprotein, this is a fucose containing ligand. This sialyl Lewis X glycoprotein, it is a fucose containing ligand. That is, it has fucose in it. Remember biochemistry, glucose, fucose, it has fucose in it. So in LAD2, the enzyme fucosyl transferase, the enzyme fucosyl transferase is deficient. The enzyme fucosyl transferase is deficient. This is LAD2. This is LAD2. Next point, clinical features. Clinically, it is associated with increased risk of bacterial infections. That is very obvious. It is associated with increased risk of bacterial infections. What you need to remember is it is also associated with mental retardation. It is also associated with mental retardation and Bombay phenotype. Mental retardation and Bombay phenotype. Bombay phenotype is a special type of blood group in which H substance is absent. We will be discussing Bombay phenotype in detail in blood grouping. So those of you who want to see it at this point, you can go into the chapter of blood grouping in general pathology, blood groups, and see Bombay phenotype. These are the clinical features of LED2. Next, coming to LED1. It is a defect in adhesion, autosomal recessive. Now, adhesion occurs because of binding of high affinity integrins present on leukocytes with integrin ligands. So, what is the defect? LED1, it is a defect in LED1, it is a defect in beta 2 integrin. It is a defect in beta 2 integrin. What was beta 2 integrin? It was CD11A. It was CD11A slash CD18. So LED1, it is a defect in beta 2 integrin. Next point. So clinically, this again needs to be remembered. Please put a star on this. LAD2 clinically is associated with increased risk of bacterial infections. It is associated with increased risk of bacterial infections. This is very obvious. What you need to remember is it is also associated with delayed separation. It is also associated with delayed separation of umbilical cord stump. Delayed separation of umbilical cord stump has to be remembered, is asked repeatedly. This is LED1 and LED2. Those of you who are making the notes along with me, that is the best way to study. Make notes along with me. Those of you who are doing so, please leave one page below LED2. As we keep on continuing in inflammation, we will come back to this page and write down the diseases of innate immunity. Next, coming back to inflammation. Coming back to inflammation, we were done with margination, rolling, adhesion. After adhesion, the next step is diabetes. After adhesion, the next step is diabetes, which you very well know is emigration of leukocytes from the circulation. That is, they come out of the circulation, emigration of leukocytes from circulation. Just one word with this. Firstly, it occurs mainly in, where does it occur? Arterioles, capillaries, venules, या veins. Venules. It occurs mainly in post capillary venules. It occurs in post capillary. It occurs in post capillary venules. Next point. Next point. It is mediated by CD31 or PCAM. It is mediated by CD31 or PCAM. PCAM stands for platelet endothelial platelet endothelial cell adhesion molecule. It is mediated by CD31 or PCAM, platelet endothelial cell adhesion molecule. Next point. Next point. How do leukocytes traverse the basement membrane? See, endothelial contraction has taken place, so the permeability has increased. But leukocyte has to come out of the vessel wall. Below the endothelium is the basement membrane. So how do leukocytes cross the basement membrane? By secretion of collagenases. So after crossing endothelium, or the medical term is after traversing endothelium, that is after crossing the endothelium, leukocytes cross basement membrane. Leukocytes cross the basement membrane by secretion of collagenases. They cross the basement membrane by secretion of collagenases. This is diabetes, that is, the leukocytes come out of the vessel wall. After coming out, they have to go to the site of inflammation, that is chemotaxis. After coming out of the vessel wall, they have to go to the site of inflammation, that is chemotaxis. Chemotaxis. So first point, chemotaxis you already know is migration of leukocytes. It is migration of leukocytes to the site of inflammation. Migration of leukocytes to the site of inflammation, that is chemotaxis. Unidirectional or random? Obviously, it is unidirectional in nature. It is unidirectional in nature, because if it was random, the leukocyte will never reach the site of inflammation. Unidirectional. Next point, how does the leukocyte reach the site of inflammation? It is mediated by actin polymerization. Actin, which is present in the cytoplasm, It is mediated by actin polymerization. Actin, which is present in the cytoplasm of the leukocytes, polymerizes, as a result of which the cytoplasm moves forward. That is chemotaxis. Much more important than these 3 points are the chemotactic agents. Much more important than these are the chemotactic agents. Chemotactic agents, they are the substances which help in chemotaxis. So I can divide the chemotactic agents into two types, that is endogenous chemotactic agents, and exogenous chemotactic agents. Endogenous and exogenous. Exogenous are obviously the bacterial or the viral products. Exogenous are obviously the bacterial or the viral products. Wherever bacterial or viral product is present, leukocyte goes there. That is an exogenous chemotactic agent. What you need to remember and what is repeatedly asked are the endogenous chemotactic agents, which are which complement factor? C5a, C5a, leukotriene B4, LTB4, leukotriene B4, interleukin 1, interleukin 8, and TNF alpha, tumor necrosis factor alpha. C5a, leukotriene B4, interleukin 1, interleukin 8, and TNF alpha has to be remembered. Next, let us see other questions associated with this. First question, most potent chemotactic agent, C5a. नहीं बचे, leukotriene B4. Most potent chemotactic agent, leukotriene B4. Complement factor, which is the most potent chemotactic agent, C5a. Next point, interleukin 1. What is the main role of interleukin 1? It is the most potent pyrogen. It is the most potent pyrogen, that is, it causes fever. Now, with pyrogen, it has been asked so many times that now they do not even give the option of interleukin 1. So, most potent pyrogen, interleukin 1, followed by interleukin 6, followed by interleukin 6. If interleukin 6 is also not in the options, followed by PGE2, followed by prostaglandin E2, PGE2. Next point, TNF alpha. The main role of TNF alpha is it plays a role in sepsis. Tumor necrosis factor alpha, it plays a role in sepsis. These are the chemotactic agents. Next point. Now the leukocyte has reached the site of inflammation. After reaching the site of inflammation, it has to recognize the microbe. So the next step in inflammation is recognition of microbe. Recognition of the microbe. How does leukocyte recognize after reaching the site of inflammation that this is the leukocyte? How does it recognize that this is the microbe? This is the microbe. Answer, by various receptors. The first recognition receptor, the first recognition receptor are the mannose lectin binding agents, are the mannose lectin binding agents. What do we mean by this? This means that bacterial cell wall, this means that bacterial cell wall has mannose on it. Bacterial cell wall has mannose on it, whereas leukocytes have mannose binding receptors. So this mannose of the bacterial cell wall goes and binds to the mannose binding receptor. So the leukocyte will know that this is bacteria. I'll repeat. It was very simple. The first recognition receptor was mannose-lectin binding receptors. How does it work? Leukocytes have mannose-lectin binding receptor. Bacterial cell wall has mannose. So this mannose goes and binds to the mannose binding receptor, helping in its recognition. So first is mannose-lectin binding receptors. Next are the next category of receptors for recognition are the scavenger receptors. Next are the scavenger receptors. Scavenger receptors. Scavenger receptors, they bind microbes and oxidized LDL particles. Scavenger receptors. These bind microbes. These bind microbes and oxidized LDL particles. And the oxidized LDL particles. These oxidized LDL particles, they can no longer bind to the usual LDL receptor. I'll just write it for you. These oxidized LDL particles, they no longer bind to LDL receptors. On the other hand, they bind to scavenger receptors. So the first recognition agent was the mannose-lectin binding agents. Next are the scavenger receptors, which binds microbes. Next are the integrins, macrophage integrins. Next recognition receptor are the macrophage integrins. Macrophage integrins, these are the MAC1 integrins. MAC1, macrophage integrins, that is the MAC1 integrins. Which were MAC1? We did that in rolling, beta-2 integrin CD11B slash CD18. CD11B slash CD18, we did that in addition. These are the MAC1 integrins. This binds microbes for phagocytosis. Macrophage integrins, this binds microbes for phagocytosis. For phagocytosis. And the last recognition receptors are the opsonization agents. Opsonization agents, these are the substances which makes the bacteria tasty for phagocytosis. Opsonization agents, these are the substances which makes the bacteria tasty for phagocytosis. This is not my language, this is what Robbins says for opsonization agents. So before we go to the opsonization agents, let us have a quick recap of what we have done in recognition of the microbe. See, leukocytes have reached the site of inflammation. After reaching there, the leukocyte has to recognize the microbe. There are four main receptors: mannose-lectin binding agents, scavenger receptors, macrophage integrins, and opsonization agents. Opsonization agents, they are the substances which makes the bacteria tasty for phagocytosis. So this list of opsonization agents again is important. Answer: which complement factor? C3b. Very, very important. Do not confuse C5a, which is a chemotactic agent, with C3b, which is an opsonization agent. Next point, others are mannose. Obviously, what was making the bacteria tasty for phagocytosis? Mannose. Next, Fc fragment of IgG. Fc fragment of IgG. We will be seeing what we mean by this. Fc fragment of IgG. Next, CRP, C-reactive protein, and fibrinogen. Sorry, CRP, C-reactive protein, and fibrinogen. These are the opsonization agents. Next point, before we go further, let us see what we mean by Fc fragment of IgG. Let us see what we mean by FC fragment of IgG. देखो बच्चे, suppose this is a bacteria. Bacteria is coated with antibody. Bacteria is coated with antibody. Antibody has two ends. FAB, that is fragment antigen binding. FAB, that is fragment antigen binding. Fragment antigen binding, and FC end. Fragment antigen binding and FC end. Now, this is the leukocyte. This is the leukocyte which has FC receptors. Leukocyte which has FC receptors. So, what is making the bacteria tasty for phagocytosis? FC fragment of IgG. It goes and binds to the FC receptor. It goes and binds to the FC receptor. This is opsonization agent. FC fragment of IgG. It makes the bacteria tasty for phagocytosis. Next point. So these were the opsonization agents. After recognition of the microbe, after recognition of the microbe, it is followed by engulfment. It is followed by engulfment. Engulfment is that engulfment. Engulfment is that the cytoplasm of the leukocyte goes forward and engulfs the microbe, in turn leading to phagocytosis. In turn leading to phagocytosis. It has engulfed the microbe, phagocytosis, leading to phagolysosome formation. This phagocytosed material binds with lysosome. Phagolysosome formation, in turn leading to killing. In turn leading to killing. So phagocytosis, phagolysosome formation, in turn leading to killing. Now I will just like to add one point here. Phagocytosis. How is phagocytosis taking place? Phagocytosis, it is also mediated. It is also mediated by actin polymerization. That is, the cytoplasm of the cell goes forward and it engulfs the microbe. So both chemotaxis and phagocytosis are mediated by actin polymerization. Next point, phagocytosis, phagolysosome formation, it combines with the lysosome, phagolysosome formation, in turn leading to killing. Next point, I can divide killing into two mechanisms. Killing is important. I can divide killing into two mechanisms, that is oxygen dependent, that is oxygen dependent mechanism. Oxygen dependent dependent mechanism, and the oxygen independent mechanism. Oxygen independent mechanism. Which is the main one? Oxygen dependent or independent? Oxygen dependent. This is the main mechanism of killing, and there are two main pathways for oxygen dependent killing, which are the NADPH oxidase pathway, which are NADPH oxidase, also called as the phagocyte oxidase pathway. NADPH oxidase or the phagocyte oxidase pathway, and the next is nitric oxide synthase pathway. Nitric oxide synthase pathway, also written as NOS pathway. So killing has two pathways, oxygen dependent and independent. Oxygen dependent are NADPH oxidase and the nitric oxide synthase pathway versus oxygen independent, which are lysosomal enzymes. Oxygen independent, which are lysosomal enzymes, lysosomal enzymes and microbicidal granules and microbicidal other microbicidal granules. That is oxygen independent pathway. We will do each one of these one by one. This is killing. Starting with the first and the main mechanism, that is NADPH oxidase or the phagocyte oxidase pathway. Starting with the first topic, the main mechanism, that is NADPH oxidase. NADPH oxidase or the phagocyte oxidase pathway. NADPH oxidase or the phagocyte oxidase pathway. How does this work? Oxygen. Oxygen is acted upon by NADPH oxidase. Oxygen is acted upon by NADPH oxidase, leading to the formation of superoxide anion. Leading to the formation of superoxide anion. This superoxide anion is then acted upon by superoxide dismutase. This superoxide anion is then acted upon by superoxide dismutase. Superoxide dismutase, leading to the formation of H2O2, that is hydrogen peroxide, leading to the formation of H2O2, that is hydrogen peroxide. This H2O2 is then acted upon by myeloperoxidase or chloride. This H2O2 is then acted upon by myeloperoxidase or chloride, leading to the formation of hypochlorous anion. Leading to the formation of hypochlorous anion. This is NADPH oxidase pathway or the phagocyte oxidase pathway. I'll repeat. Oxygen, which is acted upon by NADPH oxidase, leading to the formation of superoxide anion. This superoxide anion is acted upon by superoxide dismutase, leading to H2O2, which is then acted upon by myeloperoxidase and chloride, leading to the formation of hypochlorous anion. First question to you is, this superoxide dismutase, is it pro-oxidant or an antioxidant? Answer. It is an antioxidant. It is an antioxidant. See, it is converting a free radical, that is superoxide anion, into H2O2, hydrogen peroxide. This reaction is taking place in lysosomes, so it is acted upon by myeloperoxidase or chloride. If it was a healthy person, it would have been acted upon by catalase, leading to H2O plus O2. Remember, we did the same thing under free radicals in cell injury. We saw the generation of free radical, which is by NADPH oxidase, superoxide anion is generated. Removal of free radicals, which is by superoxide dismutase, in which superoxide anion is converted to hydrogen peroxide. This is so superoxide dismutase is an antioxidant. This is NADPH oxidase pathway. Next, the next pathway of killing in the oxygen dependent mechanism is the nitric oxide synthase pathway. Next is nitric oxide synthase pathway. Nitric oxide synthase pathway, also written as NOS, nitric oxide synthase pathway. Nitric oxide synthase, this enzyme is of three types, that is endothelial nitric oxide synthase, endothelial nitric oxide synthase written as ENOS, neuronal nitric oxide synthase, neuronal nitric oxide synthase that is NNOS, and inducible nitric oxide synthase that is INOS. So nitric oxide synthase pathway. It is of three types: endothelial, neuronal, inducible. First point, just answer me this question, and it is an easy one. Which plays a major role in inflammation? 1, 2, 3. Answer. Which a inducible. I don't know. I mean, in live classes, many say endothelial. Inducible. The name tells you it is getting induced in inflammation. So major role in inflammation is by the inducible nitric oxide synthase. Major role in inflammation is by the inducible nitric oxide synthase pathway. Next point, endothelial nitric oxide synthase. The minute I'll tell the answer, I'm sure everybody will be like, yes, we knew it. Endothelial maintains vessel tone. It maintains vessel tone. It acts as a vasodilator. You knew it. It is a vasodilator. Versus neuronal nitric oxide synthase, which acts as a neurotransmitter. Versus neuronal nitric oxide synthase, which acts as a neurotransmitter. This is the nitric oxide synthase pathway. This is the nitric oxide synthase pathway. Next point. Next point. These were oxygen dependent killings. This gets us to the other side, that is oxygen independent killing. Oxygen independent. The first is, let me write the heading, oxygen independent killings. Oxygen independent killings. The first mode and the main mode of oxygen independent killings is by the lysosomal enzymes. Is by lysosomal enzymes. Lysosomal enzymes. Now, point to be noted here is I can divide lysosomal enzymes into three types. That is, or I can divide the granules into three types. That is primary granules, secondary, and tertiary granules. So, primary or eosinophilic granules, primary or eosinophilic granules, secondary or specific granules, secondary or specific granules, and tertiary granules. I can divide the lysosomal enzymes into three types: primary or eosinophilic, secondary or specific, tertiary. First point, now remembering this is important, has been asked. We'll see 2-3 examples with each, nothing major. Primary granules, they are myeloperoxidase. Primary granules, they are myeloperoxidase, myeloperoxidase and proteinase 3, myeloperoxidase and proteinase 3. Now, 5th sem students, those of you who have done CVS in college, answer bache. Which vasculitis is associated with antibodies against myeloperoxidase and proteinase 3? Which vasculitis? ANCA, anti-neutrophil cytoplasmic antibody. ANCA vasculitis. For the 3rd sem and 4th sem students who have not covered CVS, which we will do that when we study CVS vasculitis, we'll remember this at that point. We will come to this again. So primary granules, myeloperoxidase, proteinase 3. Other primary granules are acid hydrolases. Others are acid hydrolases, acid hydrolases and cathepsin G, and cathepsin G. Whether you remember acid hydrolases and cathepsin G or not, I'm okay with it, but the first two have to be remembered. Next are the secondary granules, which are alkaline phosphatase, which are alkaline phosphatase, lysozymes, lysozyme, collagenases, alkaline phosphatase, lysozyme, collagenases, and lactoferrin and lactoferrin. These are the primary and the secondary granules, has to be remembered. Another important point, okay, before we go to that, tertiary granules are gelatinases. Tertiary granules, they are gelatinases, and acid hydrolases. Gelatinases and acid hydrolases. Acid hydrolases. These are the tertiary granules. Next point, before we go further, another basic difference between primary and secondary granules is primary granules, they are secreted at high concentration. They are secreted at high concentration of agonist versus secondary granules which are secreted at lower concentration which are secreted at lower concentration of agonist which are secreted at lower concentration of agonist. So primary secreted at higher concentration of agonist versus secondary which are secreted at lower concentration. This was important, the lysosomal enzymes of the lysosomal granules. Next, this gets us to the next oxygen independent killing, that is other microbicidal, that is other microbicidal granules. Other microbicidal, just a sec, is other microbicidal granules. Just the names, nothing major. The other microbicidal granules, are defensins. They are defensins. Defensins. These are arginine-rich granule particles. Defensins. Arginine-rich. These are arginine-rich granule particles. Granule peptides which are toxic to microbes. These are arginine-rich granule peptides, defensins. Next is cathelicidin. Next, next is cathelicidin. Cathelcidins. Cathelcidins, these are the antimicrobial proteins present in neutrophils. Cathelcidins, these are present in neutrophils. They're antimicrobicidal, that is very obvious. They kill the bacteria, that's obvious. That is, these are the microbicidal granules. Point is, they are present in neutrophils. Next point, its expression is upregulated. Expression is upregulated by vitamin D. Expression of cathelcidins is upregulated by vitamin D. Next, the next is lactoferrin. Lactoferrin, we have already seen it is a component of secondary granules and is microbicidal. And the last is major basic protein. Last is major basic protein, that is MBP. We will see the role of major basic protein or MBP especially in type 1 hypersensitivity when we study immunity. Here I will just write one statement. Major basic protein are the cationic protein of eosinophils. They are the cationic protein of eosinophils. Eosinophils, they do not have much bactericidal activity, that you know, but they are mainly important for killing parasites. It is cytotoxic. It is cytotoxic to parasites. Cytotoxic to parasites. That is MBP or major basic protein. Done. This takes care. This takes care of the pathways of killing. So we divided killing into two pathways, into two types: oxygen dependent and oxygen independent. Oxygen dependent was NADPH oxidase or the phagocyte oxidase pathway, which was the main pathway. Next was nitric oxide synthase. Oxygen independent pathway were lysosomal granules and other microbicidal granules, which were defensins, cathelicidins, lactoferrin, and major basic protein.